We're going to talk today about management of acute and chronic pain in the setting of opioid use disorder. Want to acknowledge and give credit to our wonderful colleague, Dr. Bott, who created this slide set. And unfortunately doesn't join us, can't join us for the echo so much anymore, but happy to be presenting this. We have no disclosures. The objectives are to describe the clinical import of the comorbidity of opioid use disorders and pain, both chronic and acute, understand how medication for opioid use disorder, or MOUD, does not preclude the need for effective pain management, and to describe and apply some strategies to help manage pain in patients who are on MOUD. So first, just to talk briefly about prevalence. You can see several studies cited here over the years, but there is quite a range, but fairly significant prevalence in the percentage of patients with OUD who have chronic pain, ranging anywhere from 37% to 64%. And we find that this relationship's really bidirectional, but usually pain comes first. So in this large study looking at over 5,000 adults with OUD over a 10-year period, 35% reported no pain, about 10% reported OUD first and then developed pain. 15% had OUD and pain at presentation, but notably the largest percentage, about 40%, had pain first and then developed OUD. We see that patients who had chronic pain before the onset of OUD also had high rates of mental health conditions, other health conditions, and that patients who had OUD before the onset of pain were more likely to also have co-occurring substance use disorder, HIV, and hepatitis C. Just to mention, access to care is a very big issue for both OUD and chronic pain, and specifically, there are significant disparities along racial lines. They continue to persist particularly between African American and non-Hispanic white adults. As you can see from Medicare claim data, there was decreased access to both buprenorphine treatment in African American patients who simultaneously experienced more overdose deaths in the decade 2010 to 2020, more than any other racial group in the US. So we have a lot of work to do to make sure we're increasing access to care, needed treatment. And we see also in some recent studies this sort of persistence of what has been a very really shameful trend in addiction medicine and other areas of medicine, where we have a racialized approach to opioid prescribing practices, specifically in primary care settings where African American patients felt increased stigmatization when seeking treatment for chronic non-cancer pain and having co-occurring substance use disorders. So shifting gears to talk about acute pain management. This is a picture, I remember Dr. Bott saying that he got from public access on the web, but that he thought really reflected what, this was a patient's artwork and description of what the acute pain felt like. You can see overwhelm was really the way of summarizing this experience. And just to set it off with a vignette, we have AN, who's a 45-year-old female who just had shoulder surgery. She has a history of OUD and was treated in the past with methadone twice. She stopped treatment in both times. This is very common. She did experience a lapse to use. She was using about 0.5 gram twice to 3 times a day of heroin prior to her surgery. And when she was on this morphine infusion with PRN breakthrough pain prescribed, she was requesting more pain medication, reported pain 9 out of 10. Was tearful. Her vital signs were stable. And one note from the nurse who was on service said she is drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict. We don't want to worsen her addiction. And so what are some commonly held beliefs, especially in the medical profession? We see that acute pain is frequently undertreated, up to 60% in inpatient settings. There's a couple studies there referenced. Even more, we see this in patients who have substance use disorders. So I think this is changing. I hope that it's changing. And I know that this quote and data is from about a decade ago, but I think we do still have more work to do. So it is still unfortunately pretty relevant that addiction can be seen by healthcare professionals as quoted here, primarily a social problem that requires law enforcement rather than a health problem that requires prevention and treatment. And we do find that this sort of perceived controllability that some providers may feel when working with patients experiencing SUDs can equate to blaming the patient and may feel like they're being manipulated, and that can kind of affect practices of care. So what is a suggested approach? Really to accept the patient's self-reported pain. We know that pain behaviors vary widely. Vital signs like that were noted as stable in that scenario aren't always a reliable indicator of pain intensity. Also want to consider addiction or true substance use disorder versus pseudo addiction. So someone whose pain is undertreated and may be exhibiting some of the signs of SUD versus physiologic dependence. And so if required, if opioid pain medication is required, it's essential not to withhold it from people who have SUD. There's no data, despite sort of our concerns about it, that shows that acute pain management is going to worsen someone's experience of their substance use disorder. However, we do know that untreated pain can lead to cravings that increase the risk of a relapse. And a couple studies of patients on methadone showed that opioid analgesia for acute pain did not increase the chances of a relapse. So just remembering too that tolerance, so someone, for instance, who's on a baseline level of methadone for their OUD has a higher tolerance. They may need higher doses of opioids for acute pain. And the risk of respiratory suppression might be lower in patients who are opioid tolerant, but still they need significant close monitoring for respiratory depression. And also remembering that opioid agonist treatment, and this is one that does come up quite a bit as a question, understandably, from providers in the inpatient setting, particular or ER, may see someone who's on, say, buprenorphine or methadone, and want to know if that's, in itself going to be helping their pain. And really, it's treating their OUD, but it's not targeting acute pain. Again, that's related to that tolerance. Just in the interest of time, not going to spend too much on this cascade, but this is, you can kind of peek through the rainbow cascade on your left here of acute pain management suggestions as a guide for ER management. If someone's coming in on buprenorphine, you can continue their maintenance dose. You could consider dividing it, may help with their pain experience. But then you want to consider other methods. So always considering your non-opioid analgesia, remembering to non-medication analgesia, certainly, ice, immobilization, certain relaxation techniques. Your acetaminophen and NSAIDs, if not contraindicated. And then also your alternatives to opioids. So that may include interventional, so such as trigger point injections, perhaps lidocaine, your gabapentinoids, and regional nerve blocks, hematoa blocks may also be effective. Following on with this pain management, really important to feel comfortable practicing these non-opioid techniques of pain management, remembering again that patients who are on MOUD have a high opioid tolerance. Also, naltrexone, we'll talk about that a little bit more too coming up in a few slides with the chronic pain management, but remembering that it has a very high mu receptor binding affinity, and that can be really difficult to treat pain with most opioids, and so it can be overridden, but with it requires higher levels and expertise to do so. So that's one reason why we always ask patients to alert providers that they're on that. And remember too that buprenorphine has a very high binding affinity, so also requires additional strategies if treating with opioids. Methadone, again, not as high affinity, but has that long half-life and is a full mu agonist. So again, has to take that into account if also dosing with pain medication, opioid-based. So talking a little bit more about methadone, what do we do when someone presents in acute pain and they're on methadone? Important to continue the baseline methadone dose, if possible, after verifying from their clinic. And if the dose can't be verified, it's safer to break up their self-reported dose into 3 to 4 times a day dosing rather than giving it all at once. And then adding in the short-acting opioids, again, if the other non-opioid methods are not helping or fully helping. And then based on their reported dose and how they're responding to that initial dose, you can gradually adjust or increase the dose. You don't administer buprenorphine, of course, because that can precipitate withdrawal, given its high affinity and partial agonism. And if patients can't take their oral dose of methadone, they can be given IV, but it should be reduced by 1/2 to 2/3, and again, be given in those divided doses. Methadone for analgesia, and this is similar for buprenorphine, is multiple times a day dosing, and it can be prescribed by any clinician with a Schedule II license. Methadone for OUD is once a day dosing, although we will sometimes divide it based on co-occurring conditions such as chronic pain. But it's once a day dosing, and it's only liquid form through an opioid treatment program. Similarly, we'll talk about buprenorphine in acute pain for a moment. We want to again employ all our non-opioid modalities, and then we can adjust that buprenorphine dosing interval. I often find that people, whether they have chronic pain or not, are already taking a split dosing of buprenorphine. It's really very long acting, and for OUD, once a day dosing is indicated, but if they have acute pain on top of it, you can transition them at least during the time that they're experiencing their pain to more frequent dosing and possibly increase their dose. So for instance, if someone was on 2 films, 2 8-milligram films once a day, you may split that to 4 milligrams 4 times a day, but you may also increase the dose. So you could increase, for instance, from 16 milligrams to 24 milligrams. You can consider IV buprenorphine and then augment with short-acting opioids that have a really high binding affinity, such as fentanyl, will be more effective in the setting of buprenorphine, which also has that high affinity. And certainly consider consulting addiction medicine if needed. We always encourage people to call our poison center if they have questions. Inpatient, we have a consult service here. And then briefly, perioperative management. I think this is one area that's shifted quite a bit in the last decade. We used to have a lot more questions come through about this. Patients used to have to kind of hold their buprenorphine, and we don't recommend that. But it is important to be on the same page as the surgical team and anesthesia. And just in general, having things out in the open can really be safer and more effective for this. In general, patients may fear the process based on prior treatment. Providers may fear that they're being deceived or manipulated. And there's, this says lack of consensus in the field, and it's based on the preference, certainly, of the surgical team, but we are seeing this shift to more of a consensus to continue the buprenorphine, but occasionally questions do still come up. And before surgery, it's important to, confirm that multi-party consent to coordinate the care with other providers, given the SUD has that special level of privacy. And in general, again, we don't want buprenorphine to be discontinued. So the current evidence is to continue it. It in itself is a powerful analgesic, and so we want that on board and maintained, and then can be combined with other opioids. This is the paper that we would often refer to, I think still do when there's questions, from Lemke et al. Out of Stanford, that Dr. Lemke made a really nice protocol that she published in 2018. This paper this is quite wordy, but I'll just kind of point your attention to the general practice, which again, 2018, I think that these doses and practice probably has changed in that both in the age of fentanyl and kind of our understanding of just continuing the buprenorphine dose and treating on top of it. But the general gist here is determining the patient's pre-op, what their dose is of buprenorphine, and then if Lemke's protocol was if they were taking more than 12 milligrams, that you can see here, then we would taper to 12 milligrams in the few days before surgery. The idea being that you're opening up more of those mu receptors to allow treatment with other opioids. If they're taking 12 milligrams or less of buprenorphine, just continuing it. And then during surgery, continuing that 12 milligram dose and adding the indicated opioids on top of it, and then post-op returning to their pre-op dose, and remembering as well that they might need actually higher levels of post-op. And that question does come up quite a bit still now. They may need higher levels of their opioid pain medication, again, due to that tolerance effect. Okay, this is a pretty wordy slide. I think in the interest of time, I'm going to go through this one pretty quick, and we'll talk a little bit about chronic pain management before finishing up. But basic message here, right, is, again, like I said, want to make sure patients are carrying information on them if they would need emergent pain treatment, just so that the team recognizes that they're on naltrexone, which is going to block and have that high affinity to the receptor, block other opioids. Excuse me, and really that patients who are on this and are needing that level of opioids need to be closely monitored by trained professionals. So this is just breaking down the difference, what I was saying to methadone and buprenorphine. Again, you can see in the past where it says this approach not recommended, there was a tendency to stop buprenorphine before surgeries or in cases of pain, and then continue it after. This is not recommended due to risk of relapse coming off of it and then having to get back on it. But also we know that buprenorphine can be very effective in terms of pain management. These are some non-opioid pharmacologic agents that may be used in treatment of acute pain, ranging from ketamine down to your NSAIDs. And then in the last 7 minutes, let's talk a little bit about chronic pain management. Another picture that Dr. Bott found from online public art, which is quite, shows how someone is feeling so tied down by their chronic pain. Some basic considerations for us to remember that a history of opioid use disorder is the single biggest predictor misusing prescribed opioids, and so we do need to proceed with caution. The use of a multidisciplinary team approach and perhaps including consulting with pain management is recommended. And remembering our non-opioid and adjuvant medications first, and such as NSAIDs, SNRIs, tricyclics may be beneficial. And then our non-pharmacologic therapies, CBT for pain, acceptance and commitment therapy, or ACT, are therapies such as yoga and acupuncture may be beneficial as well. And then remembering that patients with chronic non-cancer pain with and without opioid use disorder have an increased risk of suicide, and that's 18% of all patients with CNCP. And so really being aware and screening for depression and other mental health conditions is essential. The having OUD increases the odds of exceeding the cutoff for this risk by over 3 times. And also having OUD is a stronger risk factor than a diagnosis of MDD, actually. So turning briefly to responsible opioid prescribing, there's been a lot of mention of this over the recent years, and especially we'll touch briefly upon how the CDC guidelines have changed. But again, we want to be aware of an individual's risk factors, use our screening tools, monitor for concerning use. We can use our urine tox screens, PMP monitoring to kind of help us understand where a patient's at, but really need to meet with them and gather their history primarily. And then just always remembering to co-prescribe any opioid, including methadone or buprenorphine, with co-prescribing naloxone. So why is this not advancing? My computer's thinking about advancing. Sorry, I'm not sure. It's a little bit frozen here, but what I'm going to talk about, because I can see it, but I don't think you can, just in the interest of time, are the CDC opioid prescription guidelines. Oh, there we go. Did it change? Yes. Yes. Okay, we're good. So what was the update, the 2022 update to the 2016 guidelines. I'm a little worried my computer might keep advancing because it looks like it's thinking about it, but I'll try to pay attention if that happens. Really what we take into consideration on that update is whether or not to initiate opioids for pain, selecting the opioid and dose, being cognizant, determined from the beginning about the duration and follow-up, and then assessing the risks associated and addressing potential harm. So it was a more pointed approach, such that we're not going to be depriving patients of needed treatment with opioid, but just being very cautious and monitoring, because how do we get to needing that update? From 1999 to 2010, that's when opioid prescribing in the US increased by about fourfold. And then in 2014, the had beneficial effects by slowing down what we were creating in medicine, but also were detrimental because the actions weren't consistent and were oftentimes affected by personal bias or other things that would limit patients' access to needed medications, and so that in turn made a lot of patients get opioids that were not prescribed. So all of this is intended to provide more patient-centered care that's hopefully safe and effective. I think in the interest of time, I'm going to skip this vignette, but it is showing how buprenorphine and chronic pain can be very useful and can help transition someone sometimes away from when they're on multiple opioids may have what's called hyperalgesia, so a picture of experiencing higher pain levels, and that can be modified by transitioning to buprenorphine. We often find that if chronic opioid analgesics are needed for pain control, it might be hard to get that when patients are on buprenorphine, however. And so in those few cases that we might need to discontinue buprenorphine maintenance. And again, as I mentioned, buprenorphine can help mitigate sometimes opioid-induced hyperalgesia, so it can go the other way that it may be more helpful. These are some reasons, I won't read through them, but you can kind of scan them why buprenorphine might be a good option as frontline analgesia for significant chronic pain. This study is helpful to look at just as evidence of how conversion from high-dose opioids to buprenorphine for chronic pain can actually sometimes help alleviate pain, again, with that thought to be that due to that hyperalgesia that could be caused by the full agonist. And so you can see here, these are morphine equivalents, and the pain score before is in blue and in red after transitioning to buprenorphine. And so you can see that at different, especially as you get higher on your doses, so probably more likely to have that hyperalgesia effect, you're going to reduce the pain quite possibly by transitioning to buprenorphine. I think because we're at the 12:30 mark, I'm just going to make sure there wasn't any other particular points to bring up. Again, we talked about buprenorphine in chronic pain, methadone in chronic pain. Some cases, the patient's opioid use disorder might be treated better with methadone maintenance than buprenorphine. And sometimes this can also avoid the possible complication of precipitated withdrawal or getting effective analgesia. And then for naltrexone in chronic pain, really patients with chronic pain that you think they're going to, in addition to other modalities, need opioid analgesia, they're really not good candidates for a naltrexone due to that antagonism. And so you'd want to consider buprenorphine or methadone. So in conclusion, we want to consider an integrated approach to acute and chronic pain, consider safety and effectiveness of pain treatment in your particular patient. Remembering how racial disparities in treatment of chronic pain and OUD are significant, and that we need to address these at an individual and healthcare systems level. And also consider the effect that stigma associated with living with OUD can play in the patient's experience and access to care. So we can all work together to combat this. And that is all.